to the Human Development Institute's third spring seminar. We welcome the participants who are joining us online through Adobe, as well as participants who are here with us at the live presentation at the University of Kentucky. Our presenters will provide an opportunity for questions this afternoon, and we welcome questions from all participants. To ask a question in Adobe, use the Raise Your Hand button on the meeting toolbar next to the audio button, or you can just simply type your questions into the chat box. Should you have any questions about CEUs, you can contact me, please. Please take a brief moment at the end of our seminar to complete a brief evaluation. The evaluation will be sent to your email address immediately after the seminar. It is really helpful as we plan for upcoming seminars. Now, to introduce today's speakers. Andy Imperato is the Executive Director of the Association of University Centers on Disabilities. Jeff Edwards is the Director of Kentucky Protection and Advocacy. The title of the seminar today is Future Directions for Disability Policy at the Federal and State Levels. I'm now going to turn it over to Jeff and Andy.
Thank you all. Good afternoon. As Walt was telling you, I'm the Director of the Kentucky Protection and Advocacy Division. I've been the Director for 2 years and been the Director. I've been the Director for 2 years and been at the agency for 20. So that last 20 years has been a really interesting time in Kentucky. When I started, we had a number of people with intellectual and developmental disabilities that have been housed at psychiatric hospitals in the state under a 202B commitment, which is supposed to commit you to a ICF ID, like Oakwood or Outwood or Hazelwood, but you had people that were living in psychiatric hospitals for 20 and 30, 40 years. And at that point in time, we had started transitioning people and assisting in that transition out of psychiatric hospitals into the community, into Medicaid waiver slots. What's really interesting is at that point in time, when you do a swing 20 years later and you think about the Kentucky legislative session, which in a lot of ways you'll find a number of people to tell you it wasn't very productive for the IDDD community. We did have a couple pieces of legislation that people fought very hard for including the ABLE Act and the Autism Bill. I think what's really interesting with the ABLE Act, when you think about it, it's one of the first times, or it is the first time that, you know, we're thinking that long-term piece that there are going to be families that have children with disabilities and they will want them to get things like another child would without depleting or knocking themselves out of Medicaid or any other kind of service. And then with the autism bill, there's a small faction that talks about why are we carving out for one group and not including everyone in this piece. That's very interesting to hear. It's after down the road there are all these little voices, and I heard someone yesterday that are popping up about this. And it seems that what we still have in the disability world, especially here, is we do not think about other disabilities as being our brothers and sisters in an advocacy movement. And I think that's so problematic at a time when we have fewer resources. And I would venture to say if we thought this last session was rough, I think 2018 is going to be just that much worse in Kentucky when we get down to looking at Medicaid dollars, healthcare reform. It's going to, I think it's going to be just ugly. And the infighting has to stop. That's something we have to start thinking about, is infighting, so to speak, within the disability communities, because there's not a time that people with mental health are out advocating for people with intellectual and developmental disabilities, or people with intellectual disabilities aren't trying to address the issues that occur in the world of brain injury. So if we are not having those conversations and speaking with one voice and talking about why Medicaid is important to everyone, why every child, we should be entering and keeping that child in a regular classroom with the necessary supports, and not sending and segregating that child all of a sudden when they hit a point elementary school or middle school. Those are things that we do not think about, that we can have a conversation about cross disability, because we silo everything completely. And I think it's here. I think we have to figure out how we're going to start speaking with one voice in the disability community, and that occurs in Kentucky to a degree with the 874K Commission. But even then, it tends to be, those people like me, the talking heads and providers and other types of advocates other than self-advocates, that are having those conversations, that are attempting to educate legislators and the public about the disability world. And it's not a constant thing. There's not that expectation that we are going to have a unified movement that is going to be run completely, that will make mistakes, that will falter. But that's what every movement has done. And so until we get to that point, I think that's huge. Until we get to that point, we're speaking with one voice, and it's not about one disability versus another. And that's not intentional, but I think that's what ends up appearing when you have a group of people that are going to talk to somebody in health and welfare, and you have one person after another that's talking about, don't cut this program, don't cut this program, don't cut this program, but you're talking about 3 different programs, and you have 20 people talking about it first, and then the second program you have 10 people, then the third program there's 3 people. Well, guess what? The 20 people are going to be heard. But if we had, the whole 30 or 40 people speaking in one voice about one issue, why we need to work together, that's going to change a lot. Those are things that we don't do in a session. We didn't do it in this legislative session. There were times when you had representatives and members of the Senate that were saying, well, you don't need to keep bringing those people up here. We know what's going on. We've talked to this Medicaid provider or this, parent group or this kind of group about what's going on. And it's kind of disheartening when you're hearing that people with disabilities are going to be a bother and a hindrance to our day if they come up here, and if it's going to take so much time for them to testify, and then if we have to have someone that's going to interpret, so to speak, of what the person is saying. That's what we're up against. That's where we are, and we have to think. We have to think about that, and it cannot be those of us that are temporarily able-bodied up there talking. We have to make sure that's who's being heard, and it's not happening. Unfortunately, it didn't happen in this session. I think we have to be very cognizant of that. I think those of you that are entering this world of disability and advocacy, you have to really think about that. And who is your client? What are you doing? What is the purpose of this? And if we're not consulting people with disabilities, why are we having this conversation with other people? We're not here to do best interest. That's not going to change perceptions of people. What's going to change is thought of equality and everybody being in the room. And the expectation that people with disabilities will be having those conversations for themselves in front of their legislators, and they will demand to be heard. And if you're not, that's the problematic piece, because that's when other people, it's assumed, are speaking for you and not speaking for yourself, and then decisions get made that do not include you. And I don't know if that's the piece you see on that.
I mean, I'll just chime in briefly. I think at the federal level, the entire disability community speaks with one voice, supports each other, we've solved all of those problems.
Okay.
No,
So
I mean,
you take the hour and 45 minutes to explain that.
Exactly. No, I mean it's the same. It's the same set of issues. You know, I was on the receiving end of the advocacy when I worked for Senator Harkin as the Disability Policy Director for the Health, Education, Labor, and Pensions Committee in the United States Senate. And what I saw, the issue that he was most passionate about was employment of people with disabilities, trying to get more people into the labor force. And I saw the disability community at each other's throats on whether we should ever allow somebody to work in a segregated setting, whether we should ever allow somebody to be paid less than minimum wage, both of which are important issues. But we had no capacity to resolve that fight within our community, so we had to go as a community to Senator Harkin and let him resolve it. And you know, we did our best. Some of the people that were fighting stopped fighting, but there was a splinter group where the compromise that we came up with wasn't good enough, and they protested his office in Iowa on the HDI anniversary because they didn't like the compromise. So, I mean, for me, what you're talking about boils down to leadership. What are we doing as a movement to cultivate the right kind of leaders, bring them into the right positions where they have a spirit of collaboration, a spirit of compromise, a spirit of listening to and putting people with disabilities first, and the capacity to meet legislators where they are and move a legislator in terms of how they think about the issue. And you know, I'm an optimist. I think we'll get there, but I think you're right that we'll get there faster if people with disabilities are in leadership roles and they're working together to try to resolve these differences.
Right. And it's going to have to be. And I think that's the only thing that changes. You know, if any movement that has been successful in this country, from the civil rights movement, the women's movement, you know, gay rights movement, those have been internal leaders. It hasn't been other people speaking for these groups. You know, you did not have, you know, a man in front talking about women's liberation. You know, just like the expectation is you would have a person of color talking about the civil rights movement in the 60s. That's what it boils down to for me. And people will falter. They will make mistakes. But I do think we will get to that generation where the expectation is that a child is a child, and we are going to do our best to educate them and to give them the supports they need to be successful. And that begins by allowing people as children to make mistakes. So you learn from them, and then you get people that are 30 and 40 and 50 years old that have never been allowed to just be a human being. They have, you know, it's that we put everybody in bubble wrap, and we don't want them to do anything, and then God forbid they do something like, I would assume it's usually like something everybody in this room has done. It's just this person had a case manager or somebody living with them that documented everything they did 24 hours a day. And wouldn't that be a way to live? And then you end up being told you can't make decisions and you make bad decisions. And so we take everything away from you. And that's, you know, the history of how we've dealt with people with disabilities. And then we have to start changing the thought process. It's got to be a cultural change about that we have to assume that people are going to make mistakes and they're going to learn from them just like everybody else does, because that's what being human is about. I also, one of the pieces that we've talked about a lot in this session among different groups, and is still monumental because of what's going on with Medicaid in the state, and not only in Kentucky, but nationally, you know, is the Olmstead decision and how that impacts waiting lists of people. And when we have, what is it right now? Like, I could ask Claudia, altogether like 10,000 probably. Is it that many? For SCL, Michelle P, and everything?
Probably 79.
Okay.
79. Oh, I was thinking 3.
So, when you are, you're looking at people.
Jeff, I don't know
No.
if everybody in the audience knows what the Olmstead
Oh,
decision is.
that's
Do you want
probably
to
a
just
good idea.
describe?
A few years ago, there were a couple of women in Georgia that had been living in a hospital for a number of years, and they were ready to leave. They had teams that said they were ready to leave. And they sued the state of Georgia, and Mr. Olmstead was the director of their services, of the department, so to speak, in Georgia at the time. So it went up to the Supreme Court. And what the Olmstead decision said is, if a person's ready to leave and you have a team that's ready to leave and you get into issues, then you should be working on transition. People should be moving out of long-term institutional placement. You should not live for 30 and 40 years in the same place is the expectation of Olmstead. And one of the issues that's come about here with emergency waiting lists and the like, and people love to tell me who I need to sue this week. So Claudia's always on the list, always. And
Not asking to be sued, but on the list
to be sued, right. Medicaid is always, no, and Medicaid asks for it. They really ask for it, people think. But with the Olmstead decision, you move at a reasonable rate and you take into account the physicality. How much is it going to cost to support all of these people? And when you have Medicaid that's a quarter of your state budget at this point in time, you're not going to get massive movement on waiting lists. It's not going to happen because the state can demonstrate that it is financially, it's a barrier. As much money as we would be talking. But then the flip side of it gets to be how much money for years that we did put into institutions. And some people say we still put too much money into institutions. And then the cross-disability piece gets to be with Olmstead is when you have adults that are living in personal care homes that the state now considers to be institutions. And we entered into agreement with that. So you have people that are leaving with mental illness, that are leaving these personal care homes, that are moving out with case management. There's a supplement they can apply for. They have supported employment options. Then they are able to become to use services, and it frees up a bed in the institution. Well, what we would like is those beds not to be filled, but we know they're going to continue to be filled until that system, until the mental health system has more infrastructure in Kentucky. It's the same thing. It's like we're 20 years behind on that where we were. We're having the same discussions. But there are also a number of people with intellectual developmental disabilities that have been in personal care homes for years, and they are now leaving those personal care homes and using Medicaid waiver slots. But now what's going on with Medicaid issues, that's backed those people up now. So more than likely, we're going to get approval. We'll have all these Medicaid slots that'll come open, and then they're going to be eaten up. So if you're way down on the list, you're going to be way down on the list for years and years. And unfortunately for people where there's an emergency and there's no slot, you hang out where you are until something happens. Those are budgetary issues. I mean, that's the Olmstead piece in play because we don't have the money at this point in time to make that happen. And that's goes back to why 2018, I believe, is going to be much worse of a session than we have right now.
So on that happy note.
Yeah, it's really, I'm glad I got to go first.
So Walt insisted on PowerPoint, and I feel like since he helped us develop the PowerPoint, we should use the slides. So Walt, are you going to help me advance the slides?
I can advance the slides.
Thank you.